we've got Dr. Ashit Mehta. We're starting the Procon session. Dr. Ashit Mehta will speak for the use of PNS for supraclavicular block, followed by Dr. TVS Gopal on the use of ultrasound for supraclavicular block.
I'm using a PNS technique from last 15 years and the ultrasound machine from last 4 years. Probably after a few years I may talk on ultrasound, but today I'm going to talk pro PNS. Why do you need a missile to tackle a fly? It's just a superficial block 1.5 to 1 centimeters away from the skin. Just put the needle inside and the block is over. We should use a proper armamentarium for a superficial block. Just a needle and a PNS is sufficient. We don't need such a heavy gadget to pour the drug at the supraclavicular region. It's a God-gifted block because it is superficial in nature and is only 1 to 1.5 centimeters away from the skin. If you can palpate the subclavian artery, why do you want to visualize it? Insert the needle lateral and posterior to the subclavian artery, direct to the same-sided leg and inject the drug. Select the proper endpoints and achieve 100% success rate. I mean to say here that either flexion or extension of the fingers carries a 100% success rate. Do not reposition the needle for reducing currents with proper twitches. So even if you get twitches at 0.9 to 0.8 milliamperes at for a supraclavicular block, that is sufficient. We did not have to manipulate the needle to reduce the currents. Don't worry about the accidental puncture of the subclavian artery. Just remove the needle and direct posterior to the artery and deposit the drug. No need to stimulate any nerve, apply firm pressure. Do not hit the first rib, no pneumothorax. And do not direct it medial to the boundary of the lateral head of sternocleidomastoid, where the incidence of getting the pneumothorax is very less. Grab the opportunity of a tight supraclavicular space. The tight sheet demands less drug. The onset has to be fast. There is always a dense block, very little sparing. So there is no need of ultrasound to achieve all this. The incidence of missed nerve is very less. That is, sparing of ulnar nerve is only 5% and can be very easily blocked at the elbow region if needed. Now there are hurdles with the ultrasound, like cost. The machines are not usually portable. The PNDT Act in Maharashtra. The other hurdles with ultrasound are artifacts. Needle visualization is a big challenge. Visualizing the tip of the needles, cannot always see the drag of the spread, and as the previous speaker has told, the sterility is also a big problem. We need more hands to perform the regional anesthesia with ultrasound, holding a probe with hand, putting the needle, seeing the target nerves and then injecting the drugs, monitoring the patient needs manpower. There are certain situations like this when the ultrasound machine is not working. So I am of opinion that each and every person should and must know the PNS technique, and the unavailability of such machines in private practice is known. There are limitations of ultrasound like emphysema and severe edema, where the blocks are most needed and we can perform only with PNS technique. Are there no reports of complication with USG? Vascular punctures and pneumothorax have been reported. The neurological complication following ultrasound guidance with this study has an incidence of 3.3%, which is something to worry about. And here is a study of 1000 subclavian perivascular brachial plexus block with a success rate with a nerve stimulator of 98.8% with no clinical pneumothorax. I conclude here, the experience in the field and the technique is more important than the machine. So I go with this man with PNS for the supraclavicular box. Thank you.